in. If you're not aware, if you go onto the IMS website, which is IM Society, not two S's, it's not IMS Society, .org. There's a button to donate to the Endowment for Education and Research. If you, even no amount is too small, and if you know any philanthropic people in your country who are interested in menopause and menopause education, this is a wonderful place for them to do so. Next slide. So it gives me really great pleasure to introduce Professor Jim Simon, who is truly an old friend. And, you know, I know it's a very worn out phrase, who needs no introduction or should need no introduction, but let me do it anyway. He is a board certified obstetrician gynecologist and reproductive endocrinologist. He's based in Washington, D.C., here in the United States. He's a clinical professor at the George Washington University School of Medicine, and he leads his private practice known as Intim Medicine, as in intimacy, Intim Medicine Specialists. He is truly an internationally recognized expert in menopause and women's sexual health. He's the only physician to have served as president of both the Menopause Society, when it was called NAMS, as well as ISWICH, the International Society for the Study of Women's Sexual Health. He is also known as the Menopause Whisperer. To say that he is a prolific researcher would be an understatement. I know of no one who has been involved in more clinical research, seriously, in all of my decades than Jim Simon. And he's a prolific author. He's led more than 400 clinical trials. He's published over 800 articles, abstracts, book chapters, and books. And we're really in a treat because he's going to talk to us this morning about androgen therapy beyond libido. And with that, the floor is yours, Jim.
Well, thank you. I sincerely appreciate it. And I just need to get my slides back up. And here we go. So, as Dr. Goldstein said, it's my goal today to talk about androgen therapy in postmenopausal women beyond libido. And these are my disclosures as of the beginning of this month. As Dr. Goldstein mentioned, I do a lot of clinical research, and as such, this is the reason for all of these various research, advisory, and speaker-related disclosures. I don't really believe any of them are relevant to my comments today, but they're here for your understanding. The learning objectives for this lecture are for everyone to appreciate that testosterone is clearly a female hormone, but more importantly, it has a sweet spot. A sweet spot, not exactly an endocrinologic term, but it's a sweet spot between the benefits and the risks. And this sweet spot concept is common to all reproductive hormones. I hope that we can apply the principle that testosterone is the hormone of sexual desire in women as it is in men, but with a different dose-response curve, going back to my concept of the sweet spot, and to recognize the profound effects of testosterone in women beyond just sexual function. And those that I will mention today include bone, body composition, the eye, etc. But, and this is an important but, that we need much more research to document these effects, understand associated risk, and develop consensus documents for these non-sexual function effects. There are two overriding themes for my discussion today. The first is an unmet clinical need is a reason to do research, not a reason to lower the evidentiary standard. More research, not a lower standard. And this comes from Aaron Kesselheim, who is a professor at Harvard and an expert on regulatory law. The other overriding concept is that absence of evidence is not necessarily evidence of absence. So the fact that we don't have good data on testosterone beyond libido is not necessarily evidence that that data doesn't exist. We need to go out and get it. Now, a correlate of this is when strong evidence would be expected if something existed, then the failure to find that evidence can become evidence that it doesn't exist or evidence of absence.
Bữa
I want to start out with this diagram from an old paper, review article of mine, showing that in the brain, receptor sites for estradiol and testosterone co-locate in many areas of the brain. This makes testing of androgens or natural estrogens or natural androgens like estradiol and testosterone extremely difficult because in the brain they can be intraconverted one to the other, and we really don't know if it's a testosterone effect or an estradiol effect or a combination effect. And this has hampered our ability to document in a clear scientific way many of the questions that are open to our discussion today. Now, you'll recall that I mentioned one of my goals was this sweet spot. And testosterone, like all physiologic, reproductive, and many other hormones, has a normal range. And in humans, the normal range is characteristically wide. Characteristically wide because the systems in which those hormones function need to continue to function in spite of challenges physiologically, environmentally, and other hormonally that challenge our systems and their normal function. So, a wide normal range and problems in the fact when these hormones exceed the normal range, either being too low or too high, and we'll get back to that in just a moment. Now, I know that a woman, and in particular in this case, a menopausal woman, is not a small man. I don't mean to implicate that she is, but this is an excellent review article from 2025 on the effects of testosterone in hypogonadal men. And the mechanistic effects of testosterone are similar, if not identical, in women. Not the effects, not the levels, but the physiologic underpinnings illustrated in this diagram for erectile function, where testosterone increases nitric oxide synthase and increases the availability of compounds that increase erectile function. And let's not forget the clitoris is erectile tissue, and women have residual, albeit minimal, prostate tissue that is also has erectile elements in it. So in effect, testosterone could be postulated to have the same type of effects based on the same physiologic endpoints as in men for erectile function, for erythropoiesis, illustrated here, for skeletal effects, demonstrated here, and for muscular effects, demonstrated here. Just because we haven't been able or spent adequate effort to document these underlying effects does not mean they don't exist. Absence of evidence is not evidence of absence. So today I'd like to talk about the influence of testosterone on some of these many postulated effects, which have not in nearly enough cases been adequately demonstrated. Eye health, cognitive function, mood, muscle, bone, etc. I want to emphasize that one of these effects, probably the most common complaint that I get in my sexual medicine clinic, has to do with the urogenital impact of androgens. So let's talk briefly about that. Recognize that humans are identical anatomically until the 9th week of pregnancy, 1 week and 2 months following the last menstrual period of a pregnancy. And that fetus in utero looks female. At the 9th week, the fetal gonad begins to produce androgens in the case of the male, leading to the sexual dimorphism we see very clearly between males and females demonstrated in the lowest part of the slide. I'd like to show you this cartoon emphasizing that difference. This image is meant to illustrate the indifferent fetal 8 or 9 week appearance of the genitals. And in this case, this is development of the male, and I'd like for, the female. I'd like for everyone to pay particular attention to this brown colored slit in the middle, which you could imagine at this early stage will become the vulva, vagina, or vestibule. This brown area represents the vestibular tissue of the human female. In this case, let's look again, but let's look at this indifferent anatomy as it becomes male. Recognize that that brown area that I pointed out in the female becomes the penile urethra in the male, not exposed to the outside world, unlike the female vestibule. So when a woman refers to her vagina or comes in complaining of penetrative pain, she's not differentiating, as I hope to do here, the 3 different origins of what we would call the vulva, vagina, and vestibule. The barrel of the vagina is derived from mesoderm, like skeletal muscle, bone, cartilage, etc. And it's very tough tissue with wrinkles that allow it to stretch and change pattern so as to absorb trauma, whether it's penetrative sex and its minor trauma or it's passage of a fetus or a newborn and that trauma, but it's very flexible. The vulva is skin, which is meant to keep us in and the world out, and it's strong like nails and tooth enamel, or in animals like hooves in four-legged animals. But the vestibule, what I'm pointing out here, is derived from endoderm, like the insides of our intestines, bladder, stomach, lung, liver, etc. Not tough tissue, not typically meant to be exposed, unlike the vulvar vestibule, and it is derived from endoderm and is androgen sensitive. Vestibulodynia, as illustrated here, is very painful in spite of the other apparently non-affected vaginal tissue, and it is androgen dependent, or at least hormone mediated vestibulodynia is androgen dependent, and we typically treat it with a mixture of low-dose testosterone and estradiol, or we treat the vagina with a precursor androgen that becomes testosterone when it leaks onto the vestibule. Very little data for this, but there is some suggesting both androgen dependence, differences in the androgen genetic makeup in those affected by hormone-mediated vestibulodynia and those not, and a differential effect of testosterone applied locally compared to estrogen alone. Obviously, libido is the primary area where testosterone has been tested. I'm going to spend very little time on this because I assume that everyone appreciates it, as there's quite a bit of literature on the subject. But I do want to emphasize, and emphasize strongly, this global consensus document published in 2019 and published in multiple places, agreed upon by multiple investigators, as well as you can see, multiple different societies, that suggests that testosterone has been inadequately investigated beyond libido, beyond low sexual desire, and needs further investigation. And so we agree as a global consensus document that testosterone's main, if not sole, documented indication is for low sexual desire. Obviously, low sexual desire has many causes and reasons, not only hormone deficiency. And this slide, donated to me by the late Sandra Lieblum, emphasizes many of those non-hormonal causes of low sexual desire that need to be investigated and ruled out before low sexual desire related to hormones or androgens is assumed to be the cause. Across large samples, this is a 31,000 sample survey of US women, you can see that low sexual desire here in the orange squares tends to begin to rise in prevalence at the end of the 20s, rising to a peak at the end of the 50s, and then apparently declining in prevalence. And that is simply not the case. This is low sexual desire with distress, and desire, low sexual desire, as shown in the next slide, continues to rise. This is the exact same data. Low sexual desire continues to rise until the data runs out at age 80, but the degree of distress decreases, and so the combination of low desire and distress appears to decrease. This is not the case. Most of the data on the use of hormones or testosterone specifically for low desire comes from a huge clinical development by Procter & Gamble on a testosterone patch that you can see here on this woman's abdomen. It includes all kinds of preclinical and clinical development, and nearly all of the world's data and many of the world authorities on this subject cut their teeth on this data development. Here is a summary of some of the studies, all randomized clinical trials showing the impact of this patch on sexual function, dose ranging with estrogen, without estrogen, naturally menopausal women, surgically menopausal women, a mix of both, oral estrogens, transdermal estrogens, no estrogens, etc. I want to point out that in these studies, the testosterone levels were largely in the normal reproductive age range based on the lab tests available at the time. The average testosterone level was 63. That would be at the very upper end of the normal reproductive age range. And free testosterone was similarly in the middle to the upper end of the normal reproductive age range. Endpoints of this study demonstrated that testosterone in this patch could increase desire, sexual arousal, orgasm, improve pleasure, reduce sexually related concerns, increase sexual responsiveness, and improve a woman's sexual self-image, all while decreasing her sexually related distress. This from the Aphrodite study from Dr. Susan Davis's group, published in 2008, some time ago. These were all women using this patch and not taking estrogen. We looked at the world's literature, Dr. Jill Kraft and I, and we found that there was a different dose-related sexual response in women compared to men, where in men, the more testosterone, the higher the sexual response, where in women, as evidenced by this dose-ranging study from Glenn Bronstein, shows there's an increase up to a point and then a decrease in sexual responsiveness by a variety of endpoints when testosterone levels exceeded that maximum level, about 300 micrograms per 24 hours. This applied to desire, arousal, but not to orgasm and not to pleasure, but also to concerns and self-image. So most of the endpoints, as I showed you from the paper from Aphrodite, increase up to the maximum and then decrease. Let's change gears and talk about bones. There's not a lot of data on testosterone and bone density or fractures, the gold standard, but this study stands out from Nelson Watts, looking at methyl testosterone, here listed as the androgen, a small study compared to the same amount of esterified estrogens, and you can see that there was a larger increase in BMD by DEXA over 2 years in the methyl testosterone and esterified estrogen group. Is this because of the androgen increasing bone formation? Is this because the androgen is converted in bone or in the peripheral circulation to estrogen, and the doses of estrogen were different in the two groups? We'll never know. But the answer is there was an increased, statistically significant increase in bone density changes with methyl testosterone given to these women by 12 months and continuing to 24 months. What about body composition? Well, weight gain and body mass change during the menopause transition is one of the most common complaints that I get. Dr. Simon, I'm getting fatter and it's all around my middle and my butt. Isn't there anything you could do? And the answer is there are lots of things to do. Maybe a future presentation on exactly this subject is a good plan, but it's not a hormonal plan by and large. As you can see, if menopause is time zero, weight gain and changes in body composition begin as many as 8 years before the last menstrual period. This is longitudinal data from SWAN, and very importantly demonstrates that these changes actually plateau but don't stop increasing about 4 years following the last menstrual period and begin long before the last menstrual period. There is an interesting study. It's an old one from Adrian Dobbs, just up the highway from me in Baltimore at Johns Hopkins, looking at postmenopausal women, muscle mass and lean muscle mass or body composition, again looking at relatively high doses of esterified estrogen and methyl testosterone, albeit a very short, small study comparing that combination therapy with estrogen alone. And it showed an increase in lean muscle mass, lean body mass here by DEXA compared to changes in the estrogen group over this short study, and similarly a decrease in fat mass at various areas, including the trunk in this estrogen-androgen combination therapy. Dr. Davis's group, here led by Dr. Islam, more recent publication from 2019, systematic review of the literature, demonstrates what my interpretation is similar, not different from the data I showed you. This is subject to interpretation. These are the studies that were reviewed and showed no difference in lean muscle mass with testosterone therapy. I take this to be a positive effect of testosterone, whereas the manuscript suggests that this is a negative effect of testosterone. Let me explain my point of view. This is for both lean body mass in the upper panel of the slide and total body fat in the bottom panel of the slide. If the natural effect is to lose lean and gain fat, and testosterone prevents the loss of lean and the gain of fat, I see that as a positive response. That's not the same kind of positive response I just illustrated, where there was an increase in lean and a decrease in fat, but at least in these cases, using a natural testosterone product as opposed to methyl testosterone, there was no change or maintenance of lean and body fat as opposed to a decrease in lean and an increase in body fat. But this is one of the best summaries of that data. Let's talk about dry eye disease. Now, I know the people on this webinar, are not experts in dry eye disease. If you are, feel free to comment in the Q&A. I'm not an expert either, but I do know that dry eye disease is extremely common in perimenopausal and menopausal women. The eye is kept moist using a combination of factors. What you and I would normally refer to as tears is actually a very complicated, layered mechanism of 3 layers of a tear. It's not just a tear, it's 3 different layers: a mucus layer, a watery layer, and an oily layer that is spread over our eye when we blink. And the oily layer comes from the meibomian gland, which embryologically is very similar to the sebaceous gland. Obviously, all of us, when we're teenagers, or when we watch our children or grandchildren become teenagers, are well aware that when the sebaceous apparatus wakes up in response to adrenarche, adrenal production of androgens, and ovarian production of, or testicular production of androgens, that the skin erupts with oiliness and acne. These same type tissues are present in our eye in the meibomian apparatus, which spreads an oily layer over the water and mucus that our eyes secrete when we blink, and keeps that watery mucus mixture from evaporating. And this very preliminary study from 2025 showed that addition of topical androgens could improve dry eye. Now, this is not a randomized, placebo-controlled clinical trial. It's more of a proof of concept study, but is consistent with my point here that androgens can improve meibomian secretion and reduce the symptoms of dry eye. On mood and cognitive function, we have very little information, but this is a fairly large sample published in August 24 on the impact of testosterone on mood and cognitive symptoms in both peri and postmenopausal women. It has one major flaw that cannot be ameliorated with a study of this design, and that is there's no placebo group or estrogen only direct randomized comparative group. No less important are clinical research studies like this that bring to the fore clinical experience, highly relevant clinical experience that needs to be further evaluated in a randomized, placebo or sham-controlled fashion. The results of this study are illustrated for you here, demonstrating that for these 9 cognitive and mood symptoms, that there was an improvement in the individuals that received both estrogen and androgen, or estradiol and testosterone, compared to estradiol alone. Is this a function that the testosterone converts to estradiol, and that the individuals receiving both were actually getting more estradiol? We can't tell, and we don't know how much of this difference is placebo effect, because there was no placebo treatment group. But the size of these changes from 20% or so to 35 or 45% or so suggest an independent effect in need of further evaluation. But feeling tired or lacking energy, mood, memory problems, difficulty concentrating, as well as loss of interest in sex, all are in the positive direction by adding testosterone to estradiol in a clinical sample. A few words about safety. First, short-term safety typically looks at acne, hair loss from your head, clitoromegaly, increased hair growth like face, upper lip, sideburns, and voice changes. And this review, which I've already alluded to before, demonstrated only two statistically significant changes worth mentioning. Those are increased hair growth, like facial hair and upper lip hair, and acne with androgen therapy. And this is from the majority of the randomized clinical trial literature. Others, like clitoromegaly, voice changes, and loss of hair from the head, are not seen in these physiologic dose ranges of testosterone. Longer term safety is more difficult to document, but I'd like to mention that there are two analyses, the one from Islam, which I just mentioned, and Jayasena, same year, both from excellent journals, would summarize these adverse effects as follows. I want to represent to everyone that the long-term adverse effects have not been demonstrated, and they may not be demonstrated because the sample size required is much larger, even looking at the systematic reviews, but perhaps are undocumented because the individuals in these trials, typically for low sexual desire, were generally healthy and had low risk of actual cardiovascular, breast cancer, and other risk events. So back to my physiologic window story, recognize that it is wide, but that doesn't mean one needs to push the limits of that normal physiologic window in order to properly replace testosterone in our women. And I will leave time for Q&A by finishing on the following. Transdermal testosterone is moderately effective for hypoactive sexual desire disorder. It's been demonstrated in late reproductive age women, that is to say, late perimenopausal women, data I didn't show you, but there's at least one study in the literature documenting this, and in postmenopausal women, as I've demonstrated. The goal is to maintain total testosterone levels in the physiologic premenopausal range, and I would argue using standard assay reference ranges up to or including 60 nanograms per deciliter or its equivalent. And that above that, you get very little additional efficacy and you get more adverse side effects, primarily acne and hirsutism endpoints. The consensus document, as well as my own preference, is that compounded testosterone, subcutaneous pellets, intramuscular injections, and oral formulations are not recommended for a variety of reasons. Even though I showed you data on oral formulations, they have an adverse effect on lipids and lipoproteins, raising LDL and lowering HDL cholesterol due to their first pass liver effects. And so these are typically not recommended. Pellets and compounded products have a high variability or are used at very high doses and have pharmacokinetic vagaries that make them very difficult to utilize. In the parts of the world where no female formulation is available, and that is still the majority of the world at this point, 1/10 to 1/20 of a standard male dose of 1% transdermal testosterone, which is widely available, can be considered as a starting point for therapy in our patients, and frequent monitoring to avoid over dosing our patients, or in some cases, underdosing our patients is required. I typically measure at about 6 to 8 weeks following initiation of therapy. That seems to be a reasonable concept and supported by the consensus documents available. And then finally, and perhaps most importantly, due to my focus in this talk on the non-sexual related effects, we need much more research in exploring testosterone's impact on those urogenital effects I mentioned, body weight and body composition, lean mass and skeletal health, as well as mood and cognitive symptoms. I applaud all the investigators who have put their toe in the water and tried to flush out this very difficult subject, and I will leave it at that and open it up for questions, and I hope that there are plenty of those questions at this point. And I'll just thank everybody for their kind attention and hope that they have a safe and wonderful rest of their week.
Thank you, Jim. That was absolutely wonderful. I have a number of questions, so I'm going to monopolize the floor since we got a lot of time. I know there's some comments in the chat. I will say somebody asked about taking an exam and getting a certificate. That is not the purpose of this colloquium. You people were chosen and a competitive process out of almost 300 people. This is for your knowledge and hopefully for you to spread this knowledge in your communities beyond just your personal use. But there never was an intention for an exam and a certificate. So the answer to that is a strong no. I first have a comment, and I think you alluded to this, but I want to make it strong. And then some questions. Your Newsom cognitive study, I noticed that the improvements, 30% of this, 50% of that. It seems to me that when it comes to anything subjective in the use of hormone therapy, going back 50 years, whether it's hot flashes and night sweats, whether it's most bothersome symptom in VVA-GSM trials, there's consistently a 40% placebo response. Now, you alluded to the fact that there's no placebo group, but I would say that if you give somebody an additional medication and you see, an improvement of 30%, that's exactly what I would expect if you had a placebo control, what we see with almost every placebo-controlled trial when it comes to subjective things. For instance, in the VVA-GSM trials, there's no improvement in maturation index or pH, but most bothersome symptom consistently improves 40%. So I am really suspect about that Newsom paper that you showed, and I'd be loath to even show that kind of stuff because in my experience in continuing medical education, you show that and people don't necessarily hear. You were loud and clear about no placebo group, but I think people see that kind of thing and then think that this is real.
So just one comment, and that is a bit of a schizophrenic comment. First, I want to encourage every practitioner on this call, regardless of their location around the world or their clinical practice setting or guideline, to always think about keeping track of responses to how they practice and how their patients tell them they've benefited or not benefited. Clinical development doesn't start with a huge amount of money and a drug for development. It starts in the clinic with a concept or an idea or someone's experience. And I want to congratulate Dr. Newson and her colleagues on putting together and actually measuring their clinical experience with a large sample, suggesting, as I've demonstrated and as they showed in their paper, that there were benefits for adding testosterone to estradiol on mood and cognitive function. That's the plus side of my schizophrenia. The other side is exactly what Dr. Goldstein expressed, and that is we need to take those early clinical findings, and everyone on this webinar can contribute their own, and then follow those up with properly designed, randomized, placebo-controlled, or sham-controlled trials to demonstrate whether or not Dr. Goldstein is correct that this is just the placebo effect or whether it's an actual treatment effect. And that's critical to our moving the state of the art forward when it hasn't been done before. So it's an encouragement to all of you. It's a reward in some way to my colleagues at Newson, and it's a goal for future development that we take those clinical experiences and turn them into scientifically valid investigations.
So another comment that I would make is the slide that you showed with the, basically, I think, meta-analysis or combination of all the RCTs showing only acne and alopecia as being real. Those studies were all done with appropriate female doses for hypoactive sexual desire disorder, or mostly, if I understand. My problem is when I'm seeing the things that you claim did not reach statistical significance on that slide, these are often patients who are being treated with inappropriate doses that are much, much higher, where you do see voice changes, you do see clitoromegaly. I mean, these are physiologic changes that superphysiologic levels of testosterone will give. And I think that when you show a slide like that, you need to be clear that those were well-controlled studies in terms of dosing, and what's going on in the clinic in many people's hands, you know, what we call in the States, the wild, wild west.
Yeah, I agree. And I tried to emphasize that in showing the normal physiologic range as being our target. But as I take care of a large number of female bodybuilders who are known to use juice, as it were, I see those changes all the time. I'm not talking about that. I suspect the majority of people on this call are focused on taking care of normal women who want to be fit and strong and healthy and are not competing for the leanest fat mass and the biggest muscles, posing on the weekends, all oiled up compared to their colleagues. So we won't go there, but clearly Dr. Goldstein's point that if you exceed the normal physiologic range, that you will get beyond the physiologic side effects that I've demonstrated or reviewed from the randomized clinical trials in those meta-analyses.
And next question of mine was that I found that Dobbs paper interesting, but in 2002, how did Dobbs measure body composition?
It was measured by DEXA.
24 years ago, they had the same software that we're using today?
No, they didn't have the same software, but they did have software, and it turns out that those changes look to be quite real in very short period of time and reproducible. But I would also, to Dr. Goldstein's indirect question and comment, say that we need to review and repeat those trials using testosterone in ways, rather than methyl testosterone, in ways that are consistent with the blood levels that we reviewed for those other endpoints to see over time whether or not those same findings can be reproduced. But in men, where those data are much more robust and where the delta is much larger, similar effects are pretty well documented. I want to make one other point, and it's an important clinical one. It's also an important point as we move forward in the regulatory process for developing new testosterone products for women. I've been heard to say, and I stand by it, that if you were playing darts in an English pub and the target was the target of a normal blood level for a man, you could blindfold the person holding the dart, spin them around, turn them upside down, put them on a trampoline, and let them throw the dart, and they're going to hit the bullseye because it's just that big as it relates to men. On the other hand, if we're trying to hit the target for women, the target is very small, and you have to be an excellent dart thrower, meaning you need a highly reproducible dosage form and a highly reproducible dose to hit the target even most of the time. Remember, the target in women might be 20 to 60 nanograms per deciliter, and in men, it's 300 to 900 nanograms per deciliter. This makes the differences between men and women and the development of women's products and men's products totally different, both from the product point of view and for documenting efficacy and safety.
So that's a wonderful segue into my last question, comment, whatever, which is the measurement of testosterone in the hands of us in the trenches. In other words, the technique that various labs use, the difference between free and total, mass spec versus gas, whatever, but and in addition, SHBG. So can you comment? You've thrown out the number 20 to 60. How reliable is that when I send my patient to the laboratory and God only knows where they send the blood sample to? And how do we interpret this? And how do we know that we're talking about apples and apples, not apples and oranges?
So this is a problem in the less developed world, but in the first world, we now have widely available several different testosterone assays. And the data that I'm quoting comes from assays using gas chromatography mass spectrometry or liquid chromatography mass spectrometry, GCMS, for example, and those assays are widely available in the first world, but we, the practitioners, need to order the correct test because the quick and dirty test by RIA or ELISA assays that are commonly used for men and work completely reasonable for men are not NOT, not applicable for women. So you need to order the correct test. The consensus guideline suggests measuring total testosterone, not free testosterone in women. That's another order of magnitude of a challenge. And sex hormone binding globulin can be easily measured in nearly all of the world. It's also a simple blood test that's not expensive and is not necessarily important except in individuals where that SHBG blood level exceeds 170. Write it down. If the SHBG level exceeds 170, in those large studies, a large group of them, that we used SHBG as a cofactor in those studies for testosterone patches and sex in women, there were no positive responders, sexually positive responders in women who had an SHBG level of 170 or greater. So in those women, increasing testosterone may not further improve their sexual desire, and we need to make exceptions in that case for them, but they are a relatively uncommon group of non-responders. And non-response to a standard dose of testosterone for a standard endpoint is a reason to check or go back and check or recheck sex hormone binding globulin for those criteria.
Okay, now, Elizabetta, you got your hand up.
Thank you very much. I wanted to ask two questions. First of all, are there any special references for people with surgical menopause or early menopause? Do you recommend to give testosterone therapy for anyone with that condition? And my other question is about contraindications. Are there any women that are contraindicated to testosterone to you? Thank you.
Very good questions, both of them. I will ask each of you, since I don't know you all, to not only say who you are, but where you're from, so that if I'm there, I might reach out to you. But the point here is the first question has to do with what were your questions, Elizabeth?
Early menopause or surgical menopause, those people tend to suffer more, according to my experience, from loss of libido.
Yeah, so you're very correct. The early studies with the testosterone patch were in surgically menopausal women. And in the US, that patch was brought to the FDA for approval only in surgically menopausal women. They clearly have the most decrement in their testosterone levels, and they have the highest distress about their low sexual desire. So your comment is absolutely correct. They also had the greatest response to testosterone. So I think it's incumbent upon all of us to reach out and question those women, not only about their hot flashes and their night sweats and their basic needs for hormones, bone, cardiovascular, and symptom, but also to do so as it relates to their sexual function and give them both estrogen and testosterone for a replete level of hormones. Your second question was about absolute contraindications, and there are very few because testosterone can easily be aromatized to estrogen. The most common contraindication to testosterone therapy is in those breast cancer patients who are under active treatment for their breast cancer. Whether or not following their breast cancer treatment, some subset of women could use both estrogen and testosterone, or testosterone alone, is highly controversial at this point. And working on that to try and ferret out those women and whose breast cancer would allow them a safe use of hormones following their primary treatment versus those where that may not be safe is a subject of further investigation. But Sarah Glynn and cast of the rest of us had a nice paper trying to give some rationale to who and how to treat, and that was published in the journal Menopause earlier this year.
Thank you.
Anybody else have a hand? I don't see any other hands up. There's some stuff in the chat. Although Swaraj has been saying that she can't get on her speaker, so I would suggest you put it in the chat. There's some questions.
Yeah. Good
Sure.
morning.
What's your
Can you
question?
hear me?
Yes.
Okay. Thank you, Professor Steve, and thank you, Professor Simon, for very enlightening topic. I'm Swaraj from Nepal. If you come to Nepal, please do contact me. And currently, I'm in US, Pittsburgh. So good morning from Pittsburgh. My question is, when to prescribe this testosterone solo or in combination? Another is like how long to prescribe and what dose to start with. Although the doses we have mentioned is 300 microgram, but I would be interested in knowing when to start in combination, when to start solo, and what dose to start with. Thank you, Professor.
So thank you for your questions. I am a very aggressive hormone advocate and hormone replacement devotee. And my approach is to start everyone with pretty standard doses of estrogen and progesterone to get them stable on those issues first, as their most common complaints, as with all of you, I am sure, have to do with more traditional menopausal symptoms: hot flashes, night sweats, vaginal dryness, sleep disturbance, etc. And then, if they're a candidate, after counseling, I'm very commonly offering them testosterone in addition, but in a staged effect, so that I have a better understanding of what their side effects are from and how to ameliorate them. If you start people on 4 or 5 different treatments and they have a side effect, or an allergic reaction to one of them, you're really in limbo as to what's the cause. So these are, in my opinion, long-term treatments, not just for symptoms. That may be radical to many, but I start them on symptomatic treatment, then talk to them about longer-term treatment, because it is evolving and emerging that there are many off-target benefits of menopausal hormone therapy, just as I've alluded to for androgens in this talk, and that it's very difficult to get as much benefit, including all-cause mortality benefit, from any other treatment. So I'm a strong proponent of hormone therapy for prevention of disease, even though obviously we need much more data to document those endpoints. But that's my personal opinion.
Thank you, Professor. Just to follow on to this, like in Nepal, we don't have patches as of now, both estrogen and testosterone patches not available. So testosterone, probably injections are available. In that case, how do we treat?
So I'm not a fan of testosterone injections for women, mostly because of the pharmacokinetics of testosterone injections. They tend first to overshoot the goals of our levels and then rapidly tail off, and patients get accustomed to higher doses and then feel as if they are in the absence of testosterone, even when their levels are still high. We saw this most commonly in a cohort of English, that is from the UK, patients of a decade or two ago that were given relatively high levels of testosterone in the form of subcutaneous pellets, and then would have testosterone deficiency symptoms, even though their testosterone levels were in the lower end of the normal male range. And so I'm not a big fan of injections. As it relates to the world, Nepal included, we're still working with various companies and various regulatory agencies to come to some meaningful approach to getting testosterone products approved for women. In the US, there is currently no reasonable approach to getting a testosterone